A very good morning to all of you. I am indeed humbled to be speaking here in this Academy of Hospital Administration's annual conclave. And at the outset, I bow down and humbly pay my respects to all my teachers who are here. They have all guided, mentored us and brought us here. And sirs, I really stand tall on your shoulders, and I am privileged to be discussing the topic of level 5 leadership with all of us here. So, to start, I'll start with a small, real life luminary who's been a level 5 leader. Okay, Dr. V was born into a farmer's family in 1918 in Tamil Nadu. It was a village 80 kilometers from Madurai, who he had to walk 3 miles away from his village for his basic schooling. In 1944, he completed his medical education and joined the Army Medical Corps. The next year, until the Second World War, was an eventful for Dr. V. Why it was eventful was, after the war, he suffered from rheumatoid arthritis, which made him bedridden. But he did not lose hope. He always wanted to be a gynecologist, but with this, he of course could not progress much ahead, and he had a turbulent time. So what next? He decided that he will not let the fear overpower him. He fought against all odds, and he completed his training in ophthalmology at the age of 58. What is important is the age at which most of us think of retiring and settling down. He completed his masters in ophthalmology and started now the legendary Arvind Eye Care Hospital. He dwelled deep into the processes that were there and found out some reasons how he can give value to the patients. The first challenge that the hospital was facing was of non-consumption. Non-consumption means for every 100 patients that he used to operate, there were thousands more who wanted his services. He identified that. He identified ways by, taking cue from various automobile industries like Ford and all that, how he can utilize assembly line system and economy of scales. By assembly line system, I mean that each process that is done, so he specified the areas where it will be done, and he handled lot more number of patients with absolute patient safety, almost nil zero infection rate, to make Arvind Eye Hospital what it is today. Okay, and in attributing his success, he obviously had lot of challenges, but at that point of time and with that age also, he leveraged technology and offered high quality care to all the clients. Ladies and gentlemen, this is Dr. Govindappa Venkataswamy, or the famous Dr. V, about who really is a level 5 leader. The aim of, explaining about him is for you to understand it is not the barriers and obstructions which actually stop us on our path. It is our commitment and our faith. So is level 5 leadership a mirage? That's what I'll be deliberating with all of you today. Who is a leader? A leader is a person who can influence people towards attainment of organization goal. And he actually gets the followers to follow him. He's definitely different from a manager. A leader has other attributes which gradually we will catch up. But before that, what is important for all of us as students of science is to understand what is the level of competencies of Indian healthcare leader. This was a study done at All India Institute of Medical Sciences at New Delhi, and we did evaluate the competencies of Indian healthcare leader. To start with, what is a competency? Competency is an interplay of knowledge, skill and attitude. Knowledge is what you know, skill is how you will do it, and attitude is the approach. So it is an interplay of knowledge, skill and attitude. So the objectives for the study was to identify the existing leadership competencies, assess and compare the levels of competencies with various leadership models, and recommend the leadership competencies which should be augmented in Indian healthcare scenario. I will quickly be showing you the findings. The significant competencies that were identified for healthcare leaders were, there were some technical competencies and non-technical competencies. The technical competencies are those competencies which can be trained. And the study did find out that things like financial skill, human resource management, performance management, process management, and strategic orientation, these skills, the senior healthcare leaders, mind you, the clientele was medical superintendents, directors, CEOs of various types of hospitals, right from government hospitals to corporate hospitals. So these were the competencies that were identified which could be trained to them. That means there was a need for training. And for 8 competencies, the p-value was less than 5, which means 0.05, which meant that they were statistically significant and relevant. We also did a study of trained and untrained leader. By trained, I mean those who have got a formal training in some sort of hospital administration, be it a MD degree or a PhD degree or some sort of diploma, and the untrained leaders. And the findings were equally interesting. The trained healthcare leaders, they further felt that they needed more improvement in all these 8 competencies, of which the ones in blue are the technical competencies. The untrained also committed that they needed the improvement in performance management, process management, and strategic orientation. We also did a study for public and private healthcare leaders. And in public healthcare leaders, the leaders felt that they should learn more of performance management and process management, whereas rightly private care leaders were more bothered about financial skills, HRM, the process and the performance management. You see, all of us can connect to these requirements in our individual hospitals. Okay, and then we decided that some research articles were published analyzing these studies. Domain analysis of all the 3 domains was done, and it was found that most of our leaders are still at operational level. They are yet to reach out to transformational level. That's why in Indian healthcare scenario, it is very difficult to get the leaders who are at transformational level. Of course, there are competency development strategies which are there. There are programs which are there, and these will help us in developing the leaders for the next generation. Now comes to the core topic of what a level 5 leader is. The hierarchy has been broken down into 5 levels. The lowest level is a highly capable individual who then becomes a contributing team member and a competent manager. Now the challenge comes is between level 4 and level 5 leader. This is where we have to make our minds defogged regarding who and what a level 5 leader is. I'll quickly explain that to you. Level 5 leaders are self-effacing individuals. They don't want to be seen in the public, and they have the resolve to do whatever is required. They can sell off everything, including their own property, to see that the organization reaches the heights that it deserves. And their ambition is first and foremost for their institution. They never talk about themselves, and they never want to be larger than life heroes. They are ordinary people who quietly produce extraordinary results. A bird sitting in a tree is never afraid of the branch breaking, because the trust is on the wings of the bird and not on the strength of the branch. So that should be imbibed into all of us when we step into the new age challenges and the challenges that are unforeseen. The level 5 leaders have this unwavering resolve to do what needs to be done. They are essentially servant leaders. There is a concept of windows and mirrors and other concepts that I will be discussing with you, which I have taken, of course, from the book Good to Great. So all these level 5 leaders, when there is success, what they do, they attribute it to the team. The success is always because of the team. But when they fail, then they look into the mirror and they try to see what best can be done. A big hallmark of a leader. So what makes them a level 5 leader? These are the traits: humility, modesty, humble and fearlessness, which makes them a level 5 leader. It is not always about the money. It is about the overall success of the company and to go into transformational state. It is not family based or hierarchical. It is about the human needs and what difference can the company do to the environment around them. So what are the drivers of level 5 leaders? There are 5 drivers of level 5 leader. First is first 2, then Stockdale paradox, the flywheel, the hedgehog concept, and a culture of discipline. So first, who is, as a leader, we have to identify the right person for the right role, and we should be able to channelize it in the right direction. Selection of the people fitting for the role and having a control on them when you are starting the organization is extremely important. For this, what is needed is a knowledge about what you want to do and where you want the organization. Your own knowledge development. You should have the mastery of what is it that you desire out of your organization. Stockdale paradox is an interesting concept where there was a naval officer, Admiral Stockdale, who during Vietnam War was imprisoned for 8 years. All these 8 years, he was the motivation for the team that was with him. And he kept on telling them that they never knew what is going to happen tomorrow. But he never left optimism and hope that was ingrained in them. Ultimately, all of them got released. But sustaining for those 8 years in unpredictable environment, that too as a prisoner of war, most of us lose hope. That he did not do. And this is the Stockdale paradox, which says, although we are not able to see what is coming for us, we should have faith in our ability. Then comes the hedgehog concept. What does the hedgehog concept say? The hedgehog concept say the fox may be cunning, but it is the hedgehog animal which is one big thing. And for them, they have given 3 important indicators. First is, what is it that you are the best in the world? Try to do that. And how are you going to make it economically viable? From where you will get the funding? Please be very clear before you start this. Third and most important is your passion is going to drive this. So if you take these 3 traits, I think success will come to you sooner or later. Then of course the technological accelerators, it's very important to know what kind of technology and what optimal use of technology should be there. Don't overuse technology. Don't be a handicap that you don't have the knowledge of technology. Hire the right people and let technological accelerators give you the breakthrough momentum that is required. Okay. The flywheel, initially it becomes very difficult to set the flywheel in motion. But none of us know whether it is the 15th rotation or the 16th rotation that the flywheel will start acting on its own. So to achieve that momentum, you have to keep trying. You have to keep trying. And this is what is meant by the breakthrough momentum of a flywheel. Of course, culture of discipline, needless to say. Everything should be organized. It has to be for the patients and for your HR, for your organization. So you have to do everything in a systematic manner. Okay, so what are the takeaways? Level 5 leaders, they are humble, fearless and willful. They are concerned with the company, its employees and the benefits. And they are never I person. It is always we which are the team. Believe me, most of the senior leaders who are there at level 4, they will see to it that they don't leave a proper hierarchy, and when they get out of that system, the intent is that, the system should feel their deficiency, not level 5 leaders. They will shape the organization for generations to come, so that it is the systems which will carry on, and that is how you see these great hospitals that are doing so well in our country. Finally, are they born or bred? Can I become a level 5 leader? Frankly, no prescription. I've told you the way ahead and how we can do it. If we can try capitalizing it, if we develop our own competency, then maybe someday when we want to take that step beyond what we are capable of, I'm sure we will get what we want. Okay, it seems surreal, but believe me, it is doable and achievable. And it tests your perseverance, and consistency is the key. Needless to say, it is an utopian dream for all of us, but it is achievable. Thank you so much. Thank you, sir.
Thank you, Colonel Patnaik, for this very motivating and inspiring talk. And it is apparent that we must take a leaf out of this excellent presentation and try to be something like leader 5. In the process, we may not achieve that level. We may make a level 1, 2, 3, 4, whatever. But it is definitely inspiring and captivating talk. Thank you. And I have been told that, sorry, you will announce? Okay.
Thank you, sir. Now I would request Dr. D.K. Sharma, sir, to felicitate Colonel Dr. Saroj Patnaik, sir. Yes, sir. Since he has to leave quickly. Thank you, sir. I want to continue the session.
Yeah, I believe that now we are going to have online presentation by Dr. Pradipta Chaudhury. So we can connect with him. Or no, it is... wahi. Can the organizers clarify? Because you announced that second will be online presentation, but the slide is showing as number 3, General Behera. Connecting, okay. Yeah, good morning, Dr. Pradeep Chaudhury. Can you hear us? I think you are muted. We are not able to hear you. Yeah, your voice is there. We can increase the volume, please. Sir, we are not able to hear you so far. They are doing some corrections, adjustments they are doing.
And there was a command. No, it just comes. It just comes. Thank you. Thank you. Thank you very much. Okay.
Yes, sir.
Okay. So thank you very much for inviting me to make a presentation. My presentation has two parts. One, I would briefly present some global evidence which shows the crucial role of human resources in human progress. Now this evidence is both from global history and Indian history. So I'll begin by summarizing some of this evidence and draw some important lessons from it. Then I'll draw some specific implications for governance of hospitals or hospital administration. Now, the best known economic historian of the globe over a long period is Angus Maddison. Angus Maddison's data for the last 2000 years show that from the year 1 till 1080, India was the #1 country in the world and China was the #2. India produced more than 40% of the globe's output, exported more than 40% of the globe's exports, and China was #2 with about 25-27% share. But since about 850-900, India declined and declined fast, while China started rising. And China and India crossed each other. India nosedived and China rose. China became #1 and remained #1 till 1820 with more than 33% share in global output. India's share dropped to 25% or even less. Now the question is, why did India decline and so fast? And why did China rise so fast in a short period? So what do the long period histories of China and India tell us? In fact, there's a big debate in economics and in political economy about which factors contribute the most to human progress. The debates never end. Recently, the rule of private property was sold as the most important creator of wealth and human progress in the early 2000s. Within 4 or 5 years from that, some equally well-known professors of Harvard and top universities in the US argued with evidence that it is human resource and not the rule of private property which has contributed the most to human progress. But that leaves another question. What creates human resources? What creates the conditions for high quality human resources? If you look at the history of mankind over 2000 years, we will find that there are many factors which contribute to human progress. The most important, the beginning, is natural resources. Without natural resources, you can't make a beginning. So, it's the natural resources which provide large amounts of food, enable leisure, freedom from food production, and release a large section of the population which can then devote itself to activities other than basic food gathering and food production. And in such a situation, an intelligent and needy person sees an opportunity, creates it, makes something, and makes a new technology. For example, invents steel, invents wheels, invents tools, invents machines, and so on. But it is the human resources, the human brain, which makes for the better use of natural resources. So you can easily see the primacy of human resources. It's ultimately the human brain and its development and the conditions which create human resources, which ultimately allow us to go beyond the natural resources and make progress over long periods of time. The recent history of China tells you that. The Chinese from 1978 have had phenomenal progress. This rate of progress has never been experienced anywhere in the world during any period of time. In a matter of 40 years, during these 4 decades, every target of theirs was exceeded at least by 33% and sometimes by as much as 60%. Every target of theirs. That means they underestimated their potentialities. They performed far more than they expected to do. This has been the most phenomenal success of human history. Now, what has caused that? Quite obviously, the excellent use of human resources. but what makes for excellent use of human resources. Now, if you look at the history of India, what made India the greatest civilization from the year 2500 BC till 1000 AD? If you know, you are scientists, you will know the history of science in India, that Indians made the most important advances in mathematics, in metallurgy, in science, in technology, in medicine, in surgery, in astronomy, in all these fields, and in education. The best universities in the world were in India. Now, in your hospitals, you will hear one thing. We have a problem. And what is it? Too many people. Everything is negated by having too many people in India. Now, we have to decide, is population a curse or a population a boon? There's an ideology which sees population as a curse, but there are other ideologies which see population as a boon. The Western obsession with impoverishing the others at gunpoint, bombarding and destroying other people's resources and looting their resources for their own good. These are the people who blame the exploited for their misery. So these are the people who have invented this ideology that India is poor because of its large population. There are many collaborators in India. There's a large number of people in India. Large number in absolute sense, luckily in relative sense, very small number. Indian elite, which has historically collaborated both with the Afghan nomads, Uzbek nomads, and the British in India, and continues to export very highly skilled, cheap labor to the UK and the US. These are the people who blame the population of India for India's poverty and India's all problems. Okay? But Buddhism, Confucianism, and modern Chinese state, they don't see population as a curse. They see population as a boon. Now, India has the second largest and the second strongest potential for human resources. But everyone also knows that India is doing very little to use it. Human resource is like time. If it is not used, it is wasted. So why is it properly and potentially fully used in China? And why is it not being done in India? Now, every major philosopher and every major poet has written that there is beauty and greatness hidden everywhere. We have to spot it and provide it the right opportunities and incentives. We have to provide an atmosphere which promotes the growth of human resources, the full development of human resources. Why is it that China has done so well? Anybody who's tried to understand the Chinese progress will know that it is the quality of governance. The most important institution in China is the high quality governance, which emphasizes social harmony, regional balance, emphasizes meritocracy, and a rule which is oriented towards the welfare of the common people, which tries its best to suppress individual wealth makers, doesn't let Alibaba, Tencent grow beyond a point, but doesn't stifle the market, allows the market incentives to work out, but at the same time provides every individual with the minimum necessary resources to develop her or his human resource potential and successfully eradicates poverty. This is the only large country in the world which has successfully eradicated absolute poverty by 2020. Now, India was not like this always. As I said, certainly for a long time before the year about 2000, India was a much better place where human resources were very well developed. Let's look at this past. Okay? The Buddha, who is without doubt the greatest of all teachers in human history, is in fact the founder of the hospital system. I suppose most of you will know this. The British Medical Journal in 1928 had an article which said that the modern hospital system is not actually modern. It was founded by the Buddha. The Buddha personally took care of the sick monks and trained the other monks to do so. The Buddhist monks made the advances in Ayurvedic medicine and surgery. How much time do I have? How much time do I have? Dr. Pillai, how much time do I have?
Yeah, I think you should wind up.
Sorry?
I think we are muted.
How much time do I
Unmute
have?
so that he can listen to us. Organizers, please unmute.
You can tell me 2, 3 or 4. I can't hear a long sentence. There's a problem. But you can tell me 2, 3 or 4 or 5. How many minutes?
I think you should wind up in next 2-3 minutes.
Please tell me 2, 3 or 4. I can't make out what you're saying.
2 minutes. Next 2 minutes, please. Please unmute
Yes.
me. I don't think he is able to listen to me.
Okay. The founder of the scientific system. Yeah. Okay. The founder of the scientific system was Uddalaka Aruni. But it's Buddha who made it very popular. Okay. Buddha's emphasis on Pratyakya Praman and Anuman, which was disseminated to the ordinary people through the Buddhist monks. Okay. You can hear that still. I'll give you 2 examples. The first example is a very famous Odia proverb which says, Jaha nodikhibo dui noyane, parata najiba guru bachane. That's emphasizing Buddha's words of direct evidence. Then there's a very well-known Bengali folk song which says, Jejon premer bhav janena, tar songe nai lena dena, which basically emphasizes the concept of universal love in Buddhism, which is essential for social harmony. And this song says, through various practical examples, that if somebody doesn't understand the meaning of love, I shall have nothing to do with that person. Okay. Now this is how Buddhism founded not only science in India, but also founded the medicine system, surgery. There's a lot of archaeological evidence available in Sri Lanka, Buddhist Sri Lanka, in Cambodia, in Vietnam, in Thailand, which says that there are arogyasalas, there are hospitals, there are surgeons attached to every monastery. So, what I want to emphasize is the principle and wisdom, which is far beyond compassion. And love is beyond compassion, and wisdom is beyond knowledge. Okay? Because wisdom includes social responsibility, includes social welfare, and knowledge does not include that. And love is far more than compassion because it includes a sense of equality. This is what is emphasized by Buddhism. Now, these thoughts have not died out. In the song that and the proverb that I talked about live in Odisha and Bengal. And they live in, I'm sure, in other parts of India. Such values do exist. And the hospitals operate on such values. Now I will wind up in 1 minute by saying that what I have observed in the hospitals, and our hospitals can be better governed, and hospitals administration can be better improved. I have just 4 suggestions. One is that I have found that all finances can be improved. Wastages can be reduced. The same results can be achieved with lower costs. The second point I'll make is that a big cost in hospital is time.
Excuse me, sir.
Time wasted by the wrong. Yeah. The second is the last point. I'll finish by saying that you need to create an atmosphere of social harmony and excellence, which you have. I've seen that in the All India Institute of Medical Sciences, Delhi. So you can replicate it elsewhere. You already know what to do. I'll just emphasize the Buddhist principles of wisdom and universal love. Let me stop here. Thank you very much.
Thank you. Thank you, Dr. Pradipta Chaudhury, for your interesting presentation with anecdotes from the history and intercultural comparisons. Thank you. We will now go on for the third presentation. Log out kar do. Now we will have third presentation. by Lieutenant General Dr. S.D. Behera.
Good afternoon, ladies and gentlemen.
Good afternoon, ladies and gentlemen. Thank you, Chairperson, sir. I'll also like to thank Dr. Chaudhury, who called me up somewhere in the month of April, requesting me that I had to speak during the SASH that AIIMS Bhubaneswar would be conducting. At that point of time, I was not aware that I would be. I mean, Bhubaneswar was not in the scheme of my things. So I said, what do you want me to speak about? He said, there is this policy document that has come out on the public health management cadre. What do you want to talk about it? So that was in April. I thought Jawahar will forget. But least did I know that I will land up in Bhubaneswar and be a part of the organizing committee. So there is also a requirement as an organizer to try and wind up my presentation as fast as possible. So the topic as is on the slide is challenges for the document that the Government of India has produced as a guideline, the public health management cadre, and preparing the hospital administrators for it. That would be the outline of the presentation. But the focus would be on the background to the need for this cadre, as has been explained in the government documents. Why is there a new approach required? We have had public health management for since the time of independence and well before that. Why is there a new requirement to sort of create this cadre, which they have recommended two additional cadres to be created? And any cadre creation is full of challenges. And what would be those challenges? And keeping in tune with the theme of the conference, how does this hospital administration fraternity fit into the scheme of things? My predecessor spoke about levels of leadership in healthcare settings. Level 5, level 4, and so on. But it's been noted that our public health programs and policy implementation suffers because of poor leadership and poor quality of leadership and management at all levels of governance. It's something very obvious that implementation will fail in the absence of good leadership. Generally, our leadership has comprised of general administrators and specialists who often underestimate the complexity of the public healthcare issues. And that management skills are required. Over the last few days, we've been talking about these skills, and it is so obvious that they are so complex that a generalist will not be able to undertake this or implement it without proper training. It is as if there is this understanding that if I'm have my expertise in medical science, actually it necessarily does not mean that you have competence in public health. Now, this is a definition of what is a public health worker, professional, where the Institute of Medicine USA defines it as person educated in public health, and please note the other one, or a related discipline, okay, who is employed to improve health. Now the most important part, through a population focus. Keep that word in mind, population focus, and from other related disciplines, because health and healthcare, medical, they're three different things, and health is a huge component with so many other aspects. I'm sure this audience is aware about that. And it isn't realized that the discipline of public health requires many other disciplines, medical, non-medical, and largely the understanding is that current day it is best to exploit the other disciplines that can sort of
help in the managerial management of these national health programs if we are to overcome the disease burden, if we are to able to achieve those sustained SDGs. And interestingly, there's been a shift in the way the training on public health was being done away from the medical colleges to public health schools, the world over as well as in India. By and large, the resistance to creation of this separate cadre where there has to be a population focus, where there have been other disciplines, and possibly because of the perks and privileges that it enjoys of, and that grand perk is one gadi, that one vehicle that is there to the public health officer. And mostly in the past, because of lack of trained public health personnel, it was the clinical cadre that used to tenate these appointments, and the resistance is from them that they would lose out on this perk and privilege, because while they did that, they also had the opportunity to carry on with the clinical specialties. So there was this in 2011, this excellent document that the high-level expert group, which was working on how to handle how to do the universal health coverage. In 2011, they came out with this document, 300-page document, in which the recommendation at that point was that there is a requirement for all India and state-level public health services cadre. All India means like a IAS, national level as well as state level. And a specialized state-level health system management cadre. This is 2011. So they were recommending the two cadres, one a central service like the All India Public Health Service, and the state-level health system management cadre. And obviously they said that this would help in the implementation of the national health programs and towards the universal health coverage system. And this document, while it is hard to read, but just to tell you that that document also talked about what would be the progression and growth of people who join this cadre, how would they move in the cadre. So that document discusses all that. That was in 2011. Both for the, this is this public health system management cadre, and this was for the public health cadre. Now there's a difference in the two. I'll come to that. Then comes the National Health Policy 2017, 5-6 years after this high-level committee group. And the National Health Policy 2017, that it talks about establishing a public health management cadre. Now here it is very clear. It talks about the professionals that are to be there, medical, non-medical, coming for diverse backgrounds. One thing that was sort of identified very clearly, that they should have undergone public health management training. It's not that we are doctors or anybody else just walks in, and today's world of professionalism, you need training. You need training in the domain where you would be working. What this recommendation knew? 1959, that's before I was born. The Mudaliar committee had advocated that we need to have dedicated personnel for public health management. And 73 it was followed up. There were many other committees in between. And Kartar Singh committee, well before I joined medical college, they said that doctors there is no formal training in infectious diseases, control, surveillance systems, in data management, they lack leadership and communication skills, and are ill-equipped to work in public health, public facilities. This was the Kartar Singh committee report. And the medical education that a doctor receives has hardly had any relevance to the conditions to which they are required to work in public health. Please remember, public health, it says there has to be a population focus. Doctors, by training, are hospital focused on the curative aspects largely, that when somebody comes to us, we look at it. Whereas public health tries to make the invisible visible, those faceless, nameless people who clean our streets and make it ready before we wake up, those boys who come and deliver our newspapers. That is not the focus of doctors, but that is what the public health cadre is expected to do, and that is what public health is required to do. So based on this National Health Policy, the Central Council of the Health and Family Affairs, chaired by the Honorable Health Minister, they came out with this document where they said that yes, we commit to constitute the public health management cadre as envisaged in National Health Policy by March 2022, and that would be the way to achieve the goal of health for all. And the time that Dr. Jawahar called me up, this document had just been released on 16th April 2002. Reading the title, that Public Health Management Cadre, it gives an impression that it is one cadre that is being talked about. It was a guidance document. It is a guidance document. It says that, okay, this is what we propose, but the states have the flexibility to adopt and all that. But what actually it suggested was 4 cadres. 2 are already existing in some form in most of the state, the specialist cadre, which has the doctors in the hospitals, the district hospital and all, and the others in the teaching hospitals in the medical colleges. The 2 new cadres that were proposed was the public health cadre and the health management cadre. Some states have a public health cadre, particularly Tamil Nadu, right from the time of independence. Some have created it, but no state still has the health management cadre. Now, cadre means, what is a cadre? Cadre is employment where the rules are very clearly defined for the intake, recruitment, and progression. So that is a cadre. Set of rules are defined, its intake, the entrance exam and whatever, with distinct functions. And this was the 4 cadres that were listed out in this document of 2000 this year. The first cadre was to the specialist cadre that would mainly be working in the public health facilities, in the community health centers, the district hospitals, and the tertiary care hospitals of the state. The public health cadre that would work at the PSCs, CSCs, block, district, state hospitals, and directorates, performing both primary healthcare related clinical functions as well as public functions. So the doctors could practice in the PHC as well as do these functions. And here is the third one was the health management cadre. This was mainly been designed to manage the national programs at block, district, state level. It would consist of experts of finance, HR, procurement, statistics, hospital administrators incidentally included in this, etc., with majority having postgraduate degree or diploma in public health. And the fourth cadre was the medical college teaching cadre. We had heard about this in SASH-Con 2020, when during the inaugural address, we were delighted to hear from the medical member in Niti Aayog that we are wanting to create a cadre for the health administrators, hospital administrators. We were so happy to hear about it, and they said AIIMS should put up a document to us and we will look into it. And AIIMS New Delhi did send a document. But when this document has come out, if you see where all have they identified hospital administrators, somehow the things don't fit. So what are the qualifications for this cadre? The first cadre is the clinical specialist cadre with postgraduate degrees and diploma. We are still not a clinical specialty, so we would not be there. The second is they would be MBBS doctors with either MD in community health or master's diploma in public health degree, and MBBS doctors who join this cadre would be required to do their master's program or community health within 3 to 5 years. I'm sure some of you would be thinking, what's wrong with us? In our syllabus of hospital and health administration, there is a component of healthcare administration. We'll look into that. And the third cadre, there's a new one that no state has yet, is the public health and other professional graduates to run the national health programs and public health functions, where majority would be required to have postgraduate qualification in public health, that is the 70%, and the rest would be MBAs, 30%. This percentage that they have laid down is an advisory state could tinker with it and change it. What is the advantage of having a cadre? Basically, it is people know what they have to do and they're willing. And there is, as they grow in the cadre, there is training, competency development. And those states that have a public health cadre like Tamil Nadu, Maharashtra and many other states, they rank very high in the Niti Aayog annual health index ranking. And Odisha, in fact, was the first state after 2011 when this requirement is there that the state should all develop the cadre. They were the first ones to do it in 2014. Now, cadre creation is no easy exercise. Those of us who have been HR will realize that you've got to create that pyramid structure with the reserves for training, leave deputation, have those favorable structural ratios, have those realistic threshold analysis for the growth, career growth, promotions. Otherwise, there's stagnation. There is all kind of disgruntlement, framing of the recruitment rules, and periodic cadre reviews. Yeah, I'll finish. The document also says how to go about it. It lists out, you just find out who is where, find out how many are required, give them the public health training, and that is okay with the doctors you already have. But now look at creating the health management cadre, which will be absolutely new, and do the recruitment, all those deficiencies that you exist. Now, these are the challenges. Public health is really not a priority amongst medical doctors. By our training, we are hospital-centered, who see the clinical roles to be more glamorous, prestigious, and remunerative than public health roles in rural setting, where the population focus is required. The reluctance of MBBS doctors to work in rural areas is something that need not be brought out. It is already there, and is unlikely to change if they have to get a PG degree in public health, just that overnight they will not start moving into the rural center. Resistance of clinicians will continue to be there. Increasingly, public health positions will be occupied by non-doctors. And what best that the highest body of health, WHO, is now headed by a PhD in public health, while all his 8 predecessors were doctors. I would not like to pronounce his, lest I make a mistake in the way his name is to be pronounced. But that is the shape and sign of things to come in public health. Creating 2 new cadres is going to be a huge challenge, and to train them in masters in public health, again another challenge, because we don't have many institutions offering it, and even whatever they're offering, there's poor intake, because there's so much of uncertainty. Why should I do this training? Where will I get my where will I get absorbed? Is it in the public health sector? Can it be NGOs? There's so many others, the UN, UNDP, and the government offices, policy-making bodies. So the number of seats that are available are too few to take up this, sort of help us in formalizing it early. And there are no standardization or regulatory body controlling masters in public health training, not yet. So every university has its own training format. Yes, there is a need for a Public Health Act to empower this, this cadre, otherwise it will all come to naught. Now, here it requires that if the doctors have to go into public health, the hospital admins, they are required to do a public health postgraduate training. Again, it also means that we doctors are not good enough to handle public health without a master's in public health training. And yes, it's very obvious, doctors are not trained in managerial subjects. It's come out very clearly. And medical college training in public health does not have the required orientation towards population focus. And our doctor-centric system has also been a reason for our weakness in public health implementation of policies. Now, based on this is the implication of the hospital administrators. Now, based on that, our MD hospital administrators will be required to acquire an MPH degree, unlike community medicine specialists who will directly get absorbed in that cadre. Eligibility of MDHA for public health cadre finds no mention in the curriculum, though the curriculum includes multidisciplinary content relevant to public health matters. We have components of leadership, communication, contracting, finance, health management, all that, but yet we don't find a mention in that. Given the shortage that is there in people trained in public health, I'm sure our stakeholders must impress upon the state governments that the qualified hospital administrators have training in health administration, and because the document says that the state have their own way to go about it, they should be included as being absorbed in the public health cadre without having to do a postgraduate degree. But will that help will our public health, will our MD hospital administrators want to forego the sort of glamour and glitz of a corporate hospital in tier 1 and tier 2 cities and move to the rural settings? The government has published this document, which sort of is a guiding document about the curriculum that needs standardization. Maybe our hospital ADAM course could have some tinkering based on this. Now, the public health system also includes the hospital for the success of the healthcare delivery. And like the MPH qualification that is now required public health, why should the MD hospital not be an essential qualification for terminating hospital appointments? It should be very rational that it should be there, and the medical superintendent should be all from the MD hospital administration or hospital administration training. There are very few passing out every year, hospital administration. And at the moment, it will be very hard to formalize the authorization on the establishments of the state government and the government hospital because there are too few coming out. So, remember this 2011 document. I'll finish in another 1 minute. While it talked about this 2000 document of 2019, that where they said we will create this cadre by 2022, it also had this interesting. Just read the last line. When the member Niti Aayog was discussing the creation of the public health cadre, he also said that there is a need to create a cadre of hospital managers and administrators. But it somehow has not got included in the document of this that has come out in April 2022. So, this is what I feel it should be done. There should be this, because it is a guiding document. The states can have a fifth cadre, the hospital management cadre, mainly to manage public hospitals. Now, there's a need to have this formalized in the document stage, though it is a guiding document, though the states have their own choices in such matter, but if it is mentioned there, it's not being enforced, but at least it gives us a sort of a basis for the states to be able to go ahead and create this cadre. With that, ladies and gentlemen, Chairman Sir, I rest my case.
Thank you, General Behera, for your excellent presentation on preparing hospital administrators as per new approach to public health management cadre. You have rightly said that health and public health have much wider connotation, and hospital is only a part of the overall health scenario. Your emphasis on need to have public health cadre, health management cadre at central state level as recommended by various committees and authorities is indeed important. But as you said in the end, there is a definite need to have a fifth cadre. We will have questions at the end of the session. The first speaker had to leave early. The second speaker, the communication was not so good in the presentation. Now we will have the fifth presentation. After that, we will have questions, if the time permits. Now, our fourth speaker, Dr. Rohit Jaswal from AMRI group of hospitals.
Good afternoon. At the outset, I would like to thank Dr. Jawahar Pillai and his team of AIIMS Bhubaneswar and the Bhubaneswar chapter of AHA, and especially Dr. Siddharth Mishra for inviting me for this wonderful conference. I come from the AMRI group, and we are the largest healthcare provider in the Eastern India. We have 4 hospitals and about 1,200 beds. and we are treating about 4.5 lakh patients per year. And these are some of the figures which are there for your consumption. So the topic given to me is the manpower gap in healthcare and how technology can bridge it. So I've divided my presentation into 3 parts. The first part will be some hard figures, the statistics. The second will be how the technology is helping us or will help us in bridging this gap of manpower. And the third would be the Indian context, whether India can afford to have this technology considering the huge unemployment we have. So quickly going on to the statistics, which says that Indian healthcare is growing at the rate of a CAGR of 22.9% and is going to be valued at $250 billion soon. And as per the NSSO, the doctors and the nurse and the midwives ratio, which is estimated at 6.1 and 10.6, this drops down to nearly 5 in the doctors and the other nurses to 6 when we discount the adequate qualification which are there. This is against the WHO standards of 44.5 doctors and nurses, midwives per 10,000 population. And like to point out at this stage that nearly 20% of the qualified healthcare professionals are out of active labor market. So that is also to be considered. So these are the statistics which says how the various category of healthcare workers are falling short. The 3 bars which are showing is the actual data from the NHWA, that is the National Health Workforce Account, and the second is the National Sample Survey Office, which says that when the qualification is not adjusted, and the third is when the qualification is adjusted. So we see a decrement, the decrease in the manpower which we are currently facing. And this is the projection which is giving us the 2019 baseline, what we currently are, which is, if we say that the skilled health workforce is 1.77, and we have taken a conservative number of 25 per 10,000 as compared to the WHO standards, that will be 3.42, and this is the gap in million which we are seeing. So if you can appreciate, the gap is huge. Now, can we do it? And another question is how to go about it. So now the second part of the presentation is the technology use and how to mitigate the gap in manpower. So is the manpower, the technology is the answer to the manpower gap? The answer is a yes and a no. And the second part is which I said, which I'll come later, is this technology used in the context of Indian scenario. So we are all aware what and how the technology is touching us in various aspects as we see. So there is going to be definitely a setback to certain category of workers, and these workers are these workers where the work is being on a repetitive basis. And there are a number of things which can be changed when we use technology, because these workers or the work which requires a huge headcount, and it is a huge cost to the organization. Especially the blue-collar manufacturing jobs are now being taken up by the robots. The robotic process automation, RPA, it offers a huge cost reduction, and they can work non-stop 24 hours a day, 365 days a year, and they are faster, more accurate, and they don't ask for an increment. So this is a huge thing for the organization to work for the cutting down on the cost. Now I'll stop here, because when we are talking about the technology in healthcare, I think the pandemic which has happened and which is still ongoing, if I may say, has given us a huge opportunity to use this technology for various things There have been so much of technology used during these past 2.5 years. But unfortunately, we don't have some kind of a white paper which has come out as how these technologies have helped us or are going to help us in case there is a situation similar to this in the future. To the fact that the pandemic, we had huge illnesses of the staff, the manpower shortage was there. And various vaccination, then there is this portal JobWise, which are all technology based. And whenever I'm talking about the technology in healthcare, please understand, please have it in the back of your mind that we are talking about manpower also, that manpower can be utilized or there will be a retrenchment in that manpower supply. Please understand that. So something of this technology we use because the manpower was in short supply. Just to give you an example, this gentleman, which was goes by the name of Vigo, was a robot which we use in one of our facilities to have an interaction with the patients. This is a picture of the Salt Lake Stadium which we had taken up during the pandemic and converted a kind of a field hospital, 150 bed. So to cater to the patients kept, they were not very sick patients, they were patients who were to be segregated from the home and all. So they were okay patients. So this robot was an interaction and interface to have a communication with their family and all. And sometimes it was used to give the medicine to the patients also. Similarly, the other device we used in one of the centers we had taken up, it is a contactless vital monitoring for the patients where there was no human interface. No human interface means that because of the disease, we did not want to have the exposure of the staff so that other part of the healthcare could be carried on. But if this is becoming a technology which we use or the hospital start using, so then you can understand the manpower will be reduced in those areas. So these are the technologies which which I told you about, that these are there, very prevalent. Everything has touched us in the past 2.5 years. And we are talking about the technology that we are talking about artificial intelligence, machine learning, and deep learning, which means that we started with the artificial intelligence, we have graduated to machine learning, and now the deep learning, which is giving us the leeway of diagnosing various things without the human interface, which is good also and which is scary also. I do not know how many of you are aware of how the deep learning is affecting. I have some slides in my subsequent presentation, so I can tell you how it is being helpful as well as it is scary also for the healthcare workers. So during this time when we were talking about telemedicine, this is I think a benchmark, the landmark thing which has happened in the year 2020, where the teleconsultation, which employs the technology in a big way, has been ratified by the government. And we had made a big use during the pandemic of this support. So whenever we are using or talking about the artificial intelligence, this is being used for the healthcare administration, for the clinical decision support, patient monitoring, and other healthcare intervention. So repetitive routine tasks like patient data entry, laboratory data, imaging results can be taken up by the technology and by AI. So AI technically can free up the clinicians to provide direct care for the patient and the best care. And then linking these machines to the algorithms, to electronic health records can help clinicians and administrators to retrieve accurate and context-relevant patient information. So you can imagine if the AI is used in a hospital, we can have a front office without any personnel there. And a person or a patient, a customer, client can come, walk in with a virtual card which has all its data in that and can go to various stations without any human interface. Good as well as scary also. So some technology can be used to take away the functions of human in a more accurate way. Now this is interesting. Now the technology is being used quite a bit in these areas: radiology, screening, psychiatry, primary care disease diagnosis, telemedicine, and electronic health record. So to the extent that it has been used for a second opinion, the technology based or the data which is there for the radiologist for breast cancer. And the famous IBM Watson for Oncology is the world first AI which is being used. It's a cloud-based AI platform which is having so much of data, like 290 medical journals and 200 textbooks and 12 million pages of research, which gives you an insight or input about how accurate a diagnosis can be. Then the AI being used for patient monitoring and intervention, like we have seen in the pandemic and otherwise also, as I showed you. And there are things which are being used as Da Vinci robot, which is giving us the precision on the surgical field, especially oncology. Drones are being used for delivery of medicines, nanotechnology in the making of vaccines and all. So, but at the same time, when I talk about the use of technology, we have to see that it has a direct impact. And as the figures by Accenture has been given, that United States alone will be saving $150 billion annually if they take up this artificial intelligence. So it's a huge opportunity which is there. So do we say that the AI is a panacea for all the manpower needs which can be there? It is not like that, because AI is still evolving. The complete buy-in from the medical fraternity is not there. Even the so-called the mighty IBM Watson has its limitation, because in the rectal cancer recommendation, the consensus was 85% for the rectal cancer, but it dropped down to 17.8 for the lung cancer. So there's a huge discrepancy between the two, if we are talking about the technology or the AI being used to diagnose a disease. And why AI will not replace human is because robots cannot replace empathy, and the physicians have working methods which keep evolving, as no two cases are similar, as all of us know as clinicians also. And these complex digital technology requires competent personnel who have the ability to understand. Da Vinci is a marvel, but at the end it is a human who uses the precision to get the desired or the best result. So technology can help us in some complex situation using algorithms, and with the machine learning, they may perform some surgeries. In future, definitely, there is a talk about surgery in the eye, ophthalmology, where it can be done by the robots. But ultimately, a simple maneuver like a Heimlich maneuver cannot be performed by any AI or any robot. And last but not the least is the human touch, which can only be provided by the humans. So there is another ethical and the legal part of the AI also, which is still, I will say, being evolved. It is still, I say, work in progress. It is the opportunity to improve the efficiency of healthcare delivery, but at the same time, there is a threat to privacy and confidentiality, informed consent and patient autonomy. So the American Medical Association recent adoption of the policy on AI in healthcare calls for a development of thoughtfully designed, high quality and clinically validated AI technology, which can serve as a prototype policy for the medical system. So I would say the best way forward is to train the present workforce about technology and not do away with it, and get the best efficiency and the better outcomes. Like, for example, Amazon has also adopted a lot of deep learning and AI, but they are training about 100,000 workforce in the newer technologies. So the new workforce trained in AI, machine learning, cutting edge technology will be a boon in building up this intelligent healthcare system. And it has to be integrated in our curriculum for all training, whether medical or paramedical, so that the people are aware of what to expect in the future. Now, quickly, I'll just give you an example for the Indian scenario. You know that India has a huge manpower which is not being utilized. And all these technologies which we have described in the previous slides, they come with a price. The Western and the advanced countries have a huge manpower cost. Availability of manpower, trained manpower, also is a big issue there. At the same time, India is facing a massive unemployment crisis, where the unemployment today stands around 8% of the total, which is a huge. But then, as described earlier, the number to be used in the future are huge. So we should be starting now to at least mitigate some of those numbers at some time. But we have to take care that some technology cost can be offset by cheap manpower also in India. So an analysis vis-a-vis the manpower is ideal for our situation, and we have to arrive for a knowledgeable decision whenever the money is going to be spent for technology. I will rest my case with an example, two examples in fact. I am being pursued by this company. Now this is a robotic arm, only an arm which is assisting the surgeon in his laparoscopic work. So which means that a surgeon single-handedly can perform a laparoscopic surgery. Very good. The technology is brilliant. It is a voice control as well as a toggle control laparoscope. So the surgeon has an absolute control of what he's doing. But the cost of this is 1 CR. And just imagine you get an assistant who's there, a physical assistant for 15,000, a OT technician or assistant who can help the surgeon for 15,000 rupees a month. It will take nearly 50-55 years to recover this cost. And this is not that it is one time, it is recurring cost which is there. So you can see that, as mentioned earlier, that in India we have to take it with a pinch of salt. When we are adopting for the technology, then if we can replace that thing with the manpower, it will be a great thing as far as the employment for the person concerned. But at the same time, technology is good, and we should be using in the right manner, in the right places to get the best results and the efficiency, and to give the best to the patient. Thank you, sir. Thank you very much.
Thank you, Dr. Jaswal, for your interesting presentation on using technology to bridge the manpower gaps in healthcare delivery. Sir, you have given us a very important food for thought about technology versus manpower. You have rightly said that use of technology is definitely useful, but is scary also, considering the fact that patients, after all, are human beings, and they want to be treated as human beings with empathy and personalized care rather than only mechanical care. So perhaps a mix and match of both the things would be perhaps the best option. Now I'll invite the fifth speaker, Colonel M. Rajgopal, for his presentation.
Good afternoon, ladies and gentlemen, and good afternoon to the august panel which I'm sitting with. It's a little daunting for me because all the other people on the panel are doctors and I'm the only non-doctor. And I've been given this topic of engaging clinicians, so it's a little daunting, and it's even more daunting in lighter vein, Dr. Rohit, that the doctor before me spoke about replacing manpower with technology. So that's even more challenging for me, and that's the topic that's been given. But thank you, Dr. Siddharth Mishra is here, and Dr. Pillai for having invited me for the session. Why I'm qualified to stand here is, I think, I was the CHRO for the care group of hospitals for about 11 years, handling about 13 hospitals. And then I was the CEO of an organization called the Care Institute of Health Sciences, business into medical education, simulation-based training, community care, non-communicable diseases program. For me, it was a big culture shift from teaching people in the army to kill people to teaching people in healthcare to save people. So that shift I had to make. But I think I need to talk about this a little more. And this is the organization which I started about 4 years back. And why this word transcend is, can healthcare organizations transcend to a different plane of function through people management? And having experienced all of this in the last 16, 17 years in healthcare, I think there's a dire need for this. I think the way we are running healthcare organizations, especially in the private sector, need a vast improvement and have really outlived this course where today organizations are seen as social platforms. And my topic for today is again quite challenging, is engaging clinicians. Why is it that when we talk about HR management, we're not talking so much about doctor management or even consultant doctor management, right? When I was in the care group, after about 2-3 years I was there, my chairman said that, Raj, you need to handle medical operations. I told him, sir, but I'm not a clinician. He says, that doesn't matter. So over 8 to 10 years, actually I learned a lot from the doctors which are supposed to be managing, and they taught me all what I'm going to say today. So I stand in front of you with humility that at the end of all these sessions of yesterday and today, I'm going to go away with taking more than what I can impart. But this is indeed an important subject, and I take this subject as far as HR management in the Administrative Staff College of India in Hyderabad for the MHM students, the entire series. And I think the problem also lies there in the syllabus and the course curriculum of such courses which really don't address the challenges that a hospital administrator at a junior level faces when they enter hospitals. So my topic for today, right? Engaging clinicians, challenges and solutions. I think this is the quote I've taken. I said, too often leadership teams struggle with the involvement of clinicians in quality and service initiatives. The failure to engage and involve clinicians early in change efforts can significantly slow implementation in healthcare systems. I find that doctors in private hospitals, they're almost relegated to their department or even to their patient. And they're hardly involved in the institutionalized delivery of care across the system. Why is it like that? There are many studies across the world which say that the single largest variable for a clinical outcome is actually the engagement of doctors. I mean, don't do that often enough. The HR department would probably be managing the non-doctors and sometimes don't even manage the nurses because that's left to the nursing head. And doctors are not touched. I mean, doctors take the frontline decisions. As a service provider, they cast the longest shadow on patient care. Why is it that we're not talking about doctor management? Okay, right. And what you hear from doctors generally in a corporate hospital are statements like these, which I've just started. And the only one that gets treated here are the surgeons because they bring the money. And this is what hospital administrators face when they talk to the doctors. But can we fix all of that? Can we fix all of that? And I have 4-5 very simple solutions, which I've experienced over my stay in the care group and as a CEO of one of the organizations. So I thought I'll share that with you. Of course, there are lovely books, and I would recommend that you read this particular book called How Doctors Think by Jerome Groopman. It is an international bestseller. It gives you a lot of insight, and of course, the series by Dr. Stephen Beeson, one of them is Practicing Excellence. There are a series of 3 books that he's written. One of them I'll quote again a little later. These are some books that hospital administrators should read if they want to understand what clinician management is all about. Okay, the first thing I'd like to recommend is hospitals need to have great transaction policies for clinicians. I know that the NABH and the JCI talks about a lot of these policies, but I'm afraid a lot of these policies are actually just made for drafting for assessing agencies and they're not practiced on ground. A simple thing like an induction of doctors, it's amazing that after even 2 months of a doctor having joined a hospital, the fellow doctors don't know he's there. That doctor may have a niche capability, a niche clinical capability for which another doctor is referring the patient to some other hospital. Doctors who were asked to move from one station to the other are afforded no help, no concierge services. So he's pretty much on his own to find his own accommodation and education for his children. No help. Induction of doctors needs to be done in a much, much better manner. Of course, all of this you have all heard. Code of conduct. It sounds demeaning sometimes, and some doctors find it demeaning. But the drafting of the code of conduct has got to do with why you need to do it rather than what you need to do. A lot of hospitals don't have this, do not have a physician handbook. Physicians don't know who to approach for a problem because nobody told them that. There's no single point of contact where they can contact for the next 2 months of their joining. So they're pretty much on their own. I don't have a secretary, I don't have a telephone, I don't know my cabin. I learn it over 2 months. So induction of doctors. The performance management system I know is a very sensitive topic again. So we drafted a performance management system for 10 years back for doctors, but doing a lot of research and speaking to a lot of doctors. I think the thrust line of the performance management system in India should be less to do with performance of doctors because there are issues on IT and clinical data to be thrown up, and has more to do with a conversation that improves patient care. If a doctor can be convinced that this is about a conversation with you periodically to how to improve patient care across the hospitals, that's probably more acceptable. So the PMS for doctors should really have that sort of thrust line is what my viewpoint is. Establishing clinicians' confidence and trust. And what clinicians face is this when they come. There's a breakdown of trust for the following reasons. Inadequate communication. I don't know what's happening in the hospital. And the problem should be fixed because medical operations need to fix it. And medical operations doesn't get totally into this zone and doesn't take ownership of all of that. That communication with the CEO, medical staff meetings, all these sort of things must happen with doctors if you want to establish confidence and trust. Training of clinicians. I'm very happy to hear Dr. Behera, General Behera sir, talking about this. You actually spoke what I was going to speak, a lot of it. But we all understand that doctors are trained on basic sciences and clinical sciences. Why is it they're not trained on health system sciences? Why is it they are not acquainted with subjects concerning delivery of care, which are maybe non-clinical in nature, right? And there's this quote from the American Medical Association, which says that we will never transform the prevailing system of healthcare management without transforming the prevailing system of education. They're part of the same system. Why is it that training is of course, doctors attend CMEs, but that's clinical training. But why is it training in hospitals are disproportionately addressed to managers and front office staff? Why is it that hospitals do not decide to teach doctors this? This is a book of health system sciences, which says that even doctors need to understand various other aspects of healthcare for delivery of care, whether it's IT in healthcare, whether it's clinician leadership, whether it's managing healthcare teams, whether it's basics of finance in healthcare. All of them actually impact clinical outcomes. And we don't expose our doctors to any of this. One of my classes after about 10 years, or I've been taking these classes over the last 10 to 12 years, and 2-3 years back, the head of cardiology in Continental Hospital, Dr. Mirage Rao, handed over this small parchi to me, this sheet of paper. He says, why is this not a part of the MCI syllabus? I'm 58 years old, and somebody should have told me this long back. But this is the reality, and doctors accept that training program with a lot of trepidation in the beginning, but they realize the importance towards the end. Leadership. Again, people have been talking about level 5 leadership. General Behera again spoke about leadership in public health. How can you have leadership in hospitals without doctors' involvement? Why haven't we not talking about clinician leadership? And leadership is not about positions that we know. Leadership is about inspiring care. It's a skill. And at every department, at every level, you need service leadership. You need people influencing, inspiring other people to better service care, better patient care. Again, leadership is taught to the HODs. Why is that? Why isn't a PRE or a patient service executive or a nurse being talked about leadership? And doctors, right? Clinician leadership, healthcare systems that are serious about transforming themselves must harness the energies of their clinicians by inculcating leadership skills. Healthcare transformation will require leadership, and that leadership must come substantially from doctors, whether they assume formal management roles or not. The problem is that we don't expose doctors to these skills. So they pick up through experience, which may not be the absolutely correct thing. Can we not teach doctors about this? Because during their medical education, they're not exposed to any of this. And we expect them to be great HODs and great clinical directors without having spent 1 hour with them to tell them what they're supposed to be doing. I've had these particular topics being conducted in a lot of our courses. Some of these topics are shown on the slide. There's a testimonial from the head of an emergency department in a hospital in Raipur where we conducted the course. The other thing is about teams. I know sometimes teams are taken non-seriously, but the fact is that teams don't happen as a consequence of your working together. Just because you're sitting in one department, one clinical department, one non-clinical department, you don't become a team. The logic is very simple, because teams are made of human beings, and human beings are inherently different. They come from different backgrounds, they come from different education, different society. Now to align them all together does not happen automatically. And doctors struggle to make this happen. And there is this famous quote from William Mayo about 100 years back. In 1923, William Mayo of the Mayo's Clinic said doctors who work as must do are unfortunately individualists. Few of them develop respect for the other fellow's opinion, which teamwork and group medicine requires. Many things may have changed 100 years later, but it may not be a problem with the doctor. There may be a system that's making this happen. For example, doctors come with various terms of engagement, various modes of engagement. A visiting doctor, a part-time doctor, a full-time doctor, a minimum guarantee, a fee for service. Now to make all of these people of different cadres work together is not going to happen automatically, and probably you've got to put in more effort. There's no fault of the doctor here. The system sometimes lends itself to this. In a team of a clinical team, you have a highly intellectual doctor, a highly qualified doctor, a specialist, and a housekeeping staff. So there is a hierarchy of knowledge there, which may be adding to the barriers. What I'm trying to say is that we need to be telling doctors how to do this. We need to be telling doctors how to do this. The other thing is, I find a lot of vision statement of organizations on the walls. A lot of vision statements that are handed down in healthcare organizations. My question to all of them is that how many of those vision statements which you've made about patient care primarily and the quality of service in hospitals have involved doctors? You're carrying out the visioning of an organization, and statements like this, which all have to do with service and clinical outcomes, without involving the doctors. There's no conversation with the doctors to make it happen, so it remains on the wall. It remains on the wall, and where a patient is right on top, and all your vision and mission and strategies get stacked up, it doesn't happen. It doesn't happen because you're not involved in that conversation. It remains on the wall. So when you do visioning of organizations, please have a conversation with doctors. And last I'd like to say is recognition and appreciation. We have a lot of Best Associate Awards, Best Employee Awards, Employee of the Month. What about doctors? They're also human beings, and they also require appreciation. And they spend a lot of time with patients, a lot of them overnight sitting with patients, and we don't do anything about it. What drives clinicians is not different from what drives the human spirit. Recognition and appreciation is extremely important in this context. I see a wall of fame, a hall of fame, and all that for employees. I don't see doctors' names anywhere. But there are certain organizations that do that well. They have newsletters, they have physician recognition boards, they have simple thank you notes going from the CEO, and they have emails. Can we not do all of this? Doctors face problems, work-life balance and all those problems, stress they face. You can't leave doctors just for the patient care and not involve them in all of this. Thank you so much, Chairman, sir. And this last quote with Dr. Stephen Beeson, he says, the combination of technical excellence and premier service has been inseparable. One without the other is not sufficient. The reason is simple. our patients don't have the ability to assess our clinical talent, and they assume that we can do what we spend a decade or more to learn. Our extraordinary technical abilities have become an assumption. The principle means that we have to manage, market, and convey our talent rights directly on the coattails of our ability to communicate and collaborate within ourselves and our patients. Dr. Stephen Beeson. Thank you so much, sir.
Thank you, Colonel Rajgopal, for your talk on challenges and solutions in engaging clinicians. As practicing hospital administrators, we would all agree that managing highly qualified clinicians is indeed very difficult. And one effective method, as you have elucidated, can possibly be to engage the clinicians in policies, SOPs, trainings, etc., right from the beginning. Thank you. Now we'll have the last presentation by Dr. Lakshmi Prasad, which is an online presentation from AIIMS Bhopal.
No, it is in unmute only. Okay. So my video is there, audio is there. Is it okay for it to take me now?
Yes, you can start, Dr. Lakshmi. You are audible.
Yeah, in between share screen. Did they announce?
Dr. Lakshmi Prasad, you can start. Welcome.
Yeah. That's what video. Okay. It has come. You check. You okay? No, I want to speak for a while. No, my video is there. Hello? Can I speak now? Can I start? Yeah. Very good morning to all. I am Dr. Lakshmi Prasad. I am joining from AIIMS Bhopal. I would like to, at the outset, I would like to thank Dr. Jawhar and the team of organizers, Dr. Sahu from the AIIMS Bhubaneswar, for giving us this opportunity. Then, considering other friends being there, there is Dr. Ram Mohan from AIIMS Mangalgiri, Dr. Naveen from Manipur, and Dr. Kuldev from JSS, and my colleague, Dr. Pandita from AIIMS Bhopal itself, they are physically present. I would like to acknowledge their presence as well. And I would like to greet and thank Professor D.K. Sharma sir on this occasion. So coming to my presentation, it is about the trends in the health sector investment. So for us to understand the recent trends, I would like to present the presentation to start with. How is it today? A glimpse of it. I will be sharing in the next slide. Then coming to how it was, say, 1980s. What were the challenges? Then throughout the period of this 40 years, how it has been for a period of time. So then, what are the drivers for the health sector investment? What are the policy measures? And different sectors of the health sector, how they are doing as of now. This is the gist of my presentation. So, as you could see, this is how it appears. Healthcare landscape in terms of investment, in terms of happenings, everything is happening for the, making everybody to feel bask under the glory after the, say, in the year 2000, it is all about Y2K problem, those kind of associated technological issues, and, genetically related cloning of the dolly, these kind of things. But when it comes to today, this is in 2010 to 20 onwards, say in between with COVID, mostly the health sector has taken the central role. We could see the Planning Commission of India, the Niti Aayog, they are coming out with the industrial opportunities in the health sector as such. They are propagating across the world by coming out with all kind of policy decisions, the kind of incentives, the kind of opportunities that are existing in the India. Then there is the biggest private hospital that has been opened by our Honorable Prime Minister recently. Then there is a scheme about Atmanirbhar Swasthya Bharat Yojana that was in the last year itself. That is going to change the face of all the districts, 602 districts across the country. Then there is a lot of private equity investment in the healthcare sector. That also could be seen. So coming to next, so it is all a rosy picture. Everything is happening everywhere. Every possible way the health sector is getting its due. So, but as you could see in this slide, so in the 1980s, the dawn of Indian corporate health industry. So I don't like to name and identify all these kind of things. So it was such a situation. It was mostly public investment, and when it comes to private investment, when they started to go on the corporate lines, the pioneer when he started to start the to come out with a hospital. So these are the kind of letter he was forced to write to the highest office in the country, saying that I wish I have started a bidi factory or beer factory instead of healthcare facility. So why anybody has to write such a letter with such kind of expression? So it took 2 years for that the dawn of the industry to gather the land itself, to take the land under the possession to start a hospital, because there was a land sealing act. So nothing was moving. Then there was a customs duty. Customs duty to import medical equipment was at 375%. So that is again a kind of a huge concern. That is also one reason for him to write such a letter. Then funding of the very project. There was no means to fund the project. With a lot of difficulty, he could manage some 50% of it, then remaining 50% from the own funds kind of thing. Then to get whatever the incentives that are available for the health sector, one should be going for to make it a company. There was no provision to register the kind of entity that is being planned as a company. So that was the biggest challenge. Then actually to measure your own progress, how the kind of organization was doing, what is the kind of public response or the industry response or the market response, it should get listed in the capital market. So that is also not happening. So finally in the 1983, after 3 years, they could cross all these kind of issues, and finally they could start the hospital. That was a defining moment for healthcare industry in India to look at the possible private investments and possible private contribution. Considering till before 1980, it is all about individual practitioners, nursing homes, small, kind of 2-3 people coming together and starting hospitals. But everything is changed after 1980. So pre-independence, if you consider how the healthcare investment was happening, it was more of voluntary health activity. It is more of a kind of a charity and individual practice. Then comes to since independence, if we look at after independence, so government has the mandate to provide the services to the people, and healthcare happened to be one of the prime service apart from the food security, other things. So health sector has got its role, its due recognition and the share of the investment. So there were the kind of things, 5-year plans, there were the health missions time to time, health promotion programs. All the things were attracted huge kind of investment. So it even 2012 to 17, that was a 12th 5-year plan. There are also huge investment. Then 2010 onwards, mainly time to time, huge schemes having the impact across the country under the different verticals. That is, could be medical colleges, that could be public health, that could be digital as of now, that could be focusing at district level. All these things were happening. So if we consider at the time of independence, we have 17 medical colleges with intake of some 1,600 students. Whereas now we are taking around government and private together 90,000 students annual intake we are having. So that is a huge development. So if you consider 1857, that is before 1947, about 90 years back, there were 3 colleges, medical colleges. By 1947, that is from 1857 to 47, after 90 years, the 3 medical colleges has become 17. Whereas within the span of this 75 years since independence, now we have around 600 colleges giving us annually around 990,000 medical students, apart from 60,000 PG seats also being established. That is a huge kind of public investment that is happening. So coming to private investment, till 1980s, as I was telling, it is all family practices, a kind of individuals putting up their show. Until 2000 year, you could see multi-specialty hospitals are coming, individuals for pooling their resources and starting the kind of ventures. But between 2000 to 2020, there is a huge kind of interest, even in the form of foreign direct investment. That is in the form of private equity, foreign venture capital investment, portfolio investment, then foreign institutional investment. All these things put together, actually making health sector as a most vibrant sector among the other sectors, if you even compare with. The same could be, this statement could be validated if you see Nifty, the top 50 companies which are operating in India, as per the market, the capitalization, their returns in one of these years happen to be 8% per year. But our industry players, top-notch industry players, they achieved the growth of 200% returns. They have provided the 200% of the returns by having their share value doubled. That is the kind of potential for the health sector. So everybody is not attracted. Now coming to, there are several subsectors. Health sector is not a single one. There are several subsectors. That is to start with hospitals, where we are all, when it comes to public enterprise, public recognition, there is a hospitals which are the face of the healthcare industry. So there is a huge growth, about say 40% of the growth, the entire, that 132 billion out of the 342 billion, 372 billion that is expected of the entire health sector growth, 132 billion happened to be from the hospital sector alone. This is going with the CAGR, annual compound growth rate. Every sector, subsector of the health, you making a huge strides, having a huge growth, all in the double digits. Say medical tourism, health insurance growing at the rate of 30%. Maybe hospital industry maybe is having a lesser kind of thing, if you really say 16-17%. But if you really compare with any other industry, it is much more. Then pharmaceuticals. India could be the leader for the world pharmaceuticals with a kind of potential being there. India has already captured 20% of the generic market across the globe. So it is a kind of a development that is happening, even witnessed during the kind of COVID time, where we have kind of indigenously developed vaccines catering to the needs of not only of the country, even beyond the country as well. So that is the potential. Then diagnostic centers somewhere they are the part of the hospital, somewhere there could be standalone kind of setups. They are also making huge strides. Say they're 25% only in the organized sector, that is 15% in the labs and 10% in the radiology. So all the things are making huge developments. Here right side, if you could see the kind of investment trends of both in the drug and pharmaceuticals, hospitals and medical devices. This is provided by the Niti Aayog in the latest policy document which they have provided. The same is being presented here. And the medical colleges, now they are reaching 612 over a period of time. Then other sectors within the healthcare broader sector, health insurance, as I was mentioning, it is growing by 20%. Health insurance, there at the COVID time, in that particular year, there is a 350% more underwriting of the premium in the health insurance. Now it is occupying respectable position in the non-life sector. Health insurance has occupied the respectable position. So because health insurance, though government insurance in the Ayushman Bharat, everything being there, population every year, this year, every decade, for the present decade, 70 million population are coming into the middle class. That is 7 crores. If you take Russia population, it is 15 crores. So 50% of Russia population like that, in 1 decade, we are getting into the middle class. So as middle class is growing up, so naturally out-of-pocket expenditure they can afford, and out-of-pocket expenditure being a disastrous, people are going for the health insurance. Out-of-pocket expenditure, as per the national health accounts, in 2018-19, it has come down from 60% somewhere to around 48%. That is one more, indication saying to present that government, what are the provisions government is making, that people are actually availing, having a free treatment and services, and people are simultaneously going even for the health insurance. With this, actually out-of-pocket expenditure is coming up. That is how it need to be seen. Then medical tourism, that is a huge impact. Medical tourism basically got negatively affected during the COVID time. Again, it is gaining its prominent place, and definitely it is going to make a huge strides in the coming years. We have medical tourism prospects across the globe. If you take African countries, they don't have the required kind of skilled manpower, maybe kind of the kind of infrastructure. That's why people are coming. If you take the North America or kind of European countries, the expenditure, the waiting time being more, those people will be coming to India. Then Middle East, the kind of affordability being there, then the technical expertise, the kind of manpower being the issues, people are coming here. Now, if you consider the number of accredited hospital, global accreditation, we have 37 hospitals. We are having JC accreditation. In 20 years before, it could be 0. Whereas now we have 32 hospitals having that international JC accreditation being there. For people to come down here, having their insurance, whatever they are having, still getting treated here in India is possible. So that is a medical tourism. It is taking a central place in the coming years. There is a medical tourism ministry. They established a separate board to encourage medical tourism as such in the country. So apart from this, Ayush, medical devices and biotechnology, they are also making a huge growth. Ayush, if you consider, there is a rejuvenation therapies. Though yoga is there, Ayurvedic is there, all these things are considered. Apart from treatment aspect which they are having, they have been seen as a rejuvenation therapies, for which India is attracting thousands of lakhs of people. So last year we had 7 lakhs people who has happened to come to India across the globe to avail the services under the medical tourism. So we have an Indian diaspora across the globe. 3 crore Indians were there across the globe. So those population, this is the India providing services by coming up in the technology, in the manpower and infrastructure wise, is going to give them a huge kind of option. Then medical devices. Now with the Atmanirbhar India, Make in India, with these kind of policies, MRI was developed in India itself for the first time. One Mr. Arunachalam from Bangalore, their company works, some company is there. They have come out with indigenous MRI. India, as of now, having 3,500 MRIs, and it is expected to, our requirement is projected to be around 300 to 350 MRIs per year. So, a company from India with a kind of a lesser weight and portability, with the kind of cost advantage, everything being there, definitely we are going to make a kind of an impact and make maybe earning huge foreign currency as well through this medical device industry. The same with the biotechnology. So what are the growth drivers? So what has been presented was the status and projections, how health sector, different subsectors are poised to grow. But what are the health drivers? So, from by 2022, that is now itself, health sector is expected, as per the NITI document, it is going to be reaching that level of 372 billion. And definitely there is a kind of growing population, that is 141 crores as of now we are having, that is comparing to 2021, 11 million higher than previous year. So till 1974, our population growth happened to be at the rate of some 2.4% per year. That was a peak in 1974. Now again it has come down to 0.86% of population growth from year to year. So, but our base figure happened to be 140 crores, I think. It is contributing to 1 crore population. The trend may be continued for a while till it gets stabilized. Then coming to the elderly population, and we are expected to reach 16% of our population will be under that particular category. If you consider Japan population, Japan is 12 crore population Japan is having. And if you ask which of the countries having that burden of these senior citizens, old people who are actually consuming the more of health sector resources, people say Japan. Out of 12 crores, even 20% population could be not even 2.5 crores. But as per one projection, about 30 crores of Indian population by 2050, I'm not talking about 2041, by 2050, 30 crores of Indian population is going to be in that particular category, availing huge resources of the healthcare. So these tailwinds could be a kind of a advantage for us in the health sector, but these could be headwinds some other sectors. Employment sector, those industry and all, this could be a kind of a burden kind of thing. So then infectious diseases, combination of non-communicable, we are all aware about. Then consumer class, as I was telling, middle class people are coming up. That is how there is a hello. Then insurance, I already mentioned. So policy support. So even today, our real estate sector are at
Sir, requesting to conclude soon.
Yeah. So there's a automatic route, the foreign direct investment that could come into India, that is in the health sector, not like any other sector. Health sector is much more open, and even all subsectors, including hospital construction, medical devices, and health insurance, automatic route, they are allowing 100%. When it comes to pharmacy and other things, pharmaceuticals, so some 74% is they are allowing in the brown field, and in the green field they are allowing 100%. So plethora of schemes are there, many things are, we have spoken earlier itself, PMJY, PMSSY, all the things they are contributing in a huge way. Then there is a tax incentive. Telemedicine, if we spend whatever amount we spend, 250% to that is exempted from the tax. Even if you construct a building to provide the telemedicine service, not only the telemedicine equipment, the building also is considered, that also will get exemption, because once it is given 250%, that goes beyond the telemedicine equipment expenditure what you incur. Then medical technology, tax exemption for 15 years is there. So now we talk about MRI, whatever profit they make, for 15 years it is not taxed. Then tax holidays. So international outlook, we could look at other countries, that is China in sector of pharmaceuticals, and Malaysia, Singapore, what they have done. With this, I come to my presentation. Thank you so much.
Thank you, Dr. Lakshmi Prasad, for your talk on care investment yesterday, today, and tomorrow.